Good evening, everybody. This is Dr. Rick Lehman in St. Louis, and this is In Your Corner with CORA, 9/15/2020, still in the midst of a national pandemic. And tonight we're going to talk about acromioclavicular injuries, and we've got a stellar crew here tonight. So I'm going to let everybody introduce themselves. Dr. Evans, please introduce yourself.
I'm Nate Evans. I'm an orthopedic surgeon here in Myrtle Beach, South Carolina. I work with OrthoSC, group of private practice group down here.
Super. And Amanda, go ahead. Please introduce yourself.
Hi, my name's Amanda Milanak. I'm a physical therapist at CORA Physical Therapy. I work just outside of Myrtle Beach in a small town called Socastee.
Thank you very much. Tonight we're going to talk about AC injuries, acromioclavicular injuries, and really in the reference of football injuries, and certainly it's something we see very commonly in football injuries, and we also see very commonly in something close to my heart, hockey injuries, lacrosse, etc. So before we get too boring here, let's just jump right in. And Dr. Evans, first of all, let's kind of get to some basics, and let's describe the anatomy of the AC joint, kind of the function of the conoid and the trapezoid, and the stability. What stabilizes the AC joint? And we'll talk about that before we talk about what destabilizes the AC joint.
Sure. I brought a little picture. Visuals are always helpful for me. I'm a visual learner, so this kind of stuff helps me go. So I brought a little picture here, and I'll try to bring it up as close as I can. So this is an example of a shoulder joint, and the clavicle comes across here. The acromion is the end of the shoulder blade here. And there's ligaments that make up the AC joint called the acromioclavicular ligaments. And then the ligaments that you referred to, the conoid and the trapezoid ligaments, come off of this bone called the coracoid, the kind of hook in the front of the shoulder. So these two ligaments here help stabilize vertical translation, so up and down. And then the ligaments around the AC joint itself are a little bit more for kind of anterior to posterior translation.
And tell us what the strongest part of the capsular, the AC joint ligaments are. What component of the acromioclavicular ligament stabilizes the AC joint?
So the posterior and superior parts are the strongest parts of that joint.
That's correct. Well, and that's very helpful, especially when you're examining people and you're trying to figure out, like you said, superior inferior stability and anterior posterior instability. And go ahead and it's a good segue. Tell us about the physical exam. Patient comes in, they fell off their bike, they landed right on their shoulder, have complaints of pain. How are you going to examine, and what is your physical exam as it relates to the AC joint?
So in kind of we'll talk a little bit later about kind of classification things, but in kind of some of the more minor or the lower grade injuries, usually it's just mostly pain kind of in that area. People kind of come and point to their AC joint and say, it hurts here on the top of my shoulder. So doing palpation of that area, having them do range of motion with the shoulder. A lot of times for the AC joint, cross arm movements are the most painful for them. And then sometimes we'll get kind of the higher grade injuries, and people will come in and they'll say, I have a bump, or my collarbone sticks up here. And so those are a lot more obvious. That's one of the easiest things in orthopedics, I think, to diagnose. When somebody comes in and their clavicle's sticking up a couple of centimeters, then that's not too hard of a physical exam. It's pretty obvious what's going on, and they mostly just complain that it hurts when they move it around.
Perfect. So Amanda, give us a little discussion in terms of, let me start again. Amanda, tell us about the mechanism of injury. How does somebody hurt their AC joint, both acutely, and then what leads to chronic damage or AC arthritis or osteolysis in the AC joint?
So with our acute injuries, a lot of times we see direct trauma right to the shoulder, and that's where we'll see that in the collision sports of football, hockey, lacrosse. Any type of trauma that's directed directly to the shoulder can absolutely cause a translation of that AC joint. Any fall onto elbow or outstretched hand will also cause some AC disruption. And then in terms of chronic issues to the AC joint, a lot of times repetitive movements, overhead, like Dr. Evans said, a lot of movements across body that are repetitive. as well as anything that is poor posture related. I see a ton of patients that come in with forward flex posture, rounded shoulders. Those AC joints just get overly irritated day in, day out.
And explain what leads to osteolysis in the shoulder. It's something that maybe Dr. Evans is going to see a little bit more frequently than you're going to see, or I might see in our sports population. But explain osteolysis, Amanda, and tell us what leads to osteolysis.
So osteolysis is where there's erosion at the end of the collarbone. So at the end of that clavicle. So that bone is getting worn away slowly but surely over time, and there's just not enough bone regrowth to repair it. So there's more trauma than there is growth, and that leads to the erosion and the subsequent pain.
That's perfect. Thank you. And Dr. Evans, in terms of osteolysis, explain why, also a synonym, I guess, is weightlifter shoulder. What happens when you're lifting weights? Why does that create osteolysis in your shoulder? What's the mechanism of injury in terms of significant osteolysis in somebody lifting heavy weights or repetitive weights?
Yeah, I think it's exactly that, and it's kind of what Amanda was describing, of those repetitive, high energy mechanisms over and over. So most of the weightlifters are doing bench press or fly press or anything kind of out in front of them, and that joint is kind of constantly rubbing back and forth with each other. And so doing that a couple of times throughout the day with no weight involved or with just raising your arm out doesn't cause a lot of trauma, but you start putting hundreds of pounds on that, then that can be pretty painful and pretty destructive pretty quickly. So I think the patients that I see with that kind of problem are usually younger, but weightlifters, bodybuilders, bigger males usually.
Agreed. And I think it's something in a shoulder practice or a sports practice you're going to see, or we're going to see pretty routinely. So I think the therapists out there and the people listening, physicians out there, certainly it's a disease process that's fairly common. So if we're going to go back to kind of what Amanda was talking to, the mechanism of injuring your AC joint, football, falling off your bicycle, landing on your shoulder, hockey, etc. Go ahead and describe, Dr. Evans, what you alluded to before, the classification of AC instability. What happens, and what's the progression of instability after you've injured your shoulder?
Yeah, so I've actually got another picture. This is another helpful picture here. So this is a quick classification here, but essentially it starts from grade 1 and goes down to grade 6. So grade 1 is basically just a sprain of those AC ligaments, the ligaments between the clavicle and the acromion. Grade 2 disrupts that, and the clavicle translates superiorly about 25% or so. Grade 3 disrupts both the AC ligaments and then those conoid and trapezoid ligaments we talked about, and then it can translate even more. And then 4 through 6 are more rare, higher energy mechanisms. But most of the ones we're going to see from sports injuries, whether football or falling off their bike, is mostly going to be in the first 3, I would say.
Perfect. And Amanda, so somebody comes in, they've had a grade 2 AC sprain, they saw Dr. Evans, you sent them over. How are you going to rehab conservatively? First of all, what are you going to tell that patient, and how are you going to rehab that patient conservatively? And how long is it going to take? Because the first question that patient's going to ask is, well, when can I go back to ride my bike, or when can I go back to the gym, or when can I go back to work? So kind of walk us through the rehab and the time frame in terms of the rehab, treating an AC sprain conservatively.
So step one is going to be pain management. I have to get the patient to understand that no pain, no gain does not apply to them. Pain has to be their guide. If we are feeling pain, we are causing more aggravation to the shoulder and AC joint. So we have to reduce pain, irritation, swelling using ice. Dr. Evans, do you typically prescribe anti-inflammatories for these patients?
A lot of times I'll do Aleve, ibuprofen, different over-the-counter kind of things first, and if they feel like maybe they needed something a little bit stronger, then switch to the prescription. So, but definitely a huge part of the management, the anti-inflammatories for sure.
Another modality that we have at our disposal is Iontophoresis with Dexamethasone, which would be a local anti-inflammatory delivery right to that AC joint. So we can certainly use that if it's okayed by the physician. Utilizing ice 10 to 15 minutes on, especially after any activity that causes irritation, is huge to reduce that irritation to the AC joint. From there, we look at muscle instability, flexibility deficits, muscle imbalances to help restore range of motion and get their strength going so they can resume those overhead movements and cross-body movements. But initially, we're going to want to avoid those to, again, reduce irritation. We also want to look at posture to make sure that they're not rounded. Keep their shoulders back so it opens that shoulder up, as well as their AC joint, to reduce the compression of that AC joint. And then we'll slowly but surely start to load that area again to restore their function. I think time-wise, we're right about 4 to 6 weeks, as long as we can maintain compliance with keeping pain at a low grade.
Well, I think that's exactly right. And I think sometimes at the end of the rehab, it's hard sometimes to keep some of these athletes down, so they start to feel a little bit better. They're 3 or 4 weeks, maybe they really shouldn't rush back, but again, they're back on their bike or they're in the gym, and sometimes they get a little bit sore subsequently, especially like you said with adduction. Dr. Evans, so now patient comes in, they've got that bump, you've evaluated them, you've looked to see what the displacement of the clavicle is. Explain who you treat conservatively, who you treat surgically, if anybody, and if you decide that the patient's a candidate for surgery, what is your preferred surgical go-to in terms of AC joint surgery and post-op?
Yeah, so I think you kind of nuanced the question there, which is exactly how I feel about it. I try to avoid operating on these patients as much as possible. So there's good studies, good evidence that show that conservative management of the grade 1 and 2 for sure, and then a lot of the grade 3s do just as well with conservative treatment as they do with operative intervention. And so I think helping the patient understand that's a really important part of the first visit. Talking to them about their bump, and that they're probably going to have a bump no matter what we do conservatively, but that their function will still be pretty good is a big part of it. And for some patients, they accept it, they understand it. Other patients, that's a huge deal. So if I have an in-season athlete, then I will definitely try to treat them conservatively and try to get them back to their sport sooner. And if it's something that bothers them after the season, after they've gone through therapy and rehab, we can discuss surgery. Patients I'd treat sooner, I've had a few patients that had either work obligations, or I've had a couple of guys that had like military obligations that they had to pass some physical fitness test in a few months, and they just weren't sure if they could stand, 6 to 8 weeks of trying therapy and seeing if it works before they moved on with something. Maybe some workers' compensation type of cases, things like that. But those are pretty few and far between. Most cases, we're trying conservative therapeutics. And most patients do very well with those, actually. There's a lot of professional football players. I think I saw a study that something like 40% of, or it might have been a little bit lower, 25% of quarterbacks at the NFL Combine had AC joint injuries in college, and very few of them had any kind of surgery. So high-level athletes can function without surgery. In terms of how to fix it, I mean, there's been a whole bunch of options throughout history, from putting K-wires in and putting big screws in and doing hook plates and reconstructing with suture and reconstructing with ligaments and things like that. So for me personally, the patients that I've seen and operated on, I've tended to use like a suture button type of fixation, passing the suture through the clavicle, through the coracoid, fixing that down. And then I also am a believer in adding some stability to the anterior to posterior translation. So I use another kind of suture configuration over on the AC joint. And there's different ways you can do that. And then if I have somebody that's failed a repair or some sort of secondary reconstruction, then that's when I'll turn to adding some sort of graft. So usually I'll use like an autograft, something of their own tendon, a semitendinosus, something like that, to reinforce the repair and add a couple of different techniques together.
So you would harvest semi-T, as you said, do an autograft, and is that going to be a 2-tunnel technique, a 1-tunnel technique? Explain what you do with that semitendinosus.
Yeah, so there's a bunch of different ways that you can do that. I think for me, I've always been wary of putting a lot of holes in the clavicle. I think you can get pretty devastating complications from having fractures through those holes. So for me, some of the suture buttons and things like that, you can have very small 3 millimeter holes, and the fracture risk is a lot smaller. And so if I'm doing a revision or something, it depends on what they've had in there before, but a lot of times I'll try to weave the tendon around the clavicle and tie it into itself, and then use the suture button through the clavicle, because I can do it through much smaller holes. A lot of times those tendons are going to be, 4 or 5 millimeters on the smallest, all the way up to 7 or 8 millimeters, and that diameter makes a lot bigger hole once you start getting from 4 millimeters up to 7 or 8. So that's my thought. I think it's certainly an area that there's no definitive answer. I think there's, like I said, there's been a lot of techniques, and anytime there's been a lot of techniques developed to solve a problem, it means we probably don't have the answer quite yet. So.
Right, I think that's right, and I think you hit it on the head. I think even if you fix them, they always have a little bit of residual distal clavicle height issue, and you have to prepare them for that. Otherwise, they're going to say, "Well, I still have a bump," which it will still have a bump.
Yep.
So, who is indicated for this surgery? Give me what your indications are. What patient comes in and you say, "Boy, we need to fix this AC joint," or there really is it personal preference, and there's nobody you feel? I mean, is a type 5 an indication with a hole in the deltoid, or is there any surgical indication in your mind to fix the distal clavicle or the AC joint post-trauma?
Yeah, so I think those type 4s, 5s, and 6s, like I said, are more rare, but certainly if somebody comes in and their clavicle is much more than 100% displaced, I think those people do not do well. It's for them, it's much more than just a cosmetic deformity. I mean, they can barely reach to get dressed without having pain, without irritating their deltoid, their trapezius, and everything around there. So I think those people are ones that I've fixed in the past. Like I said, some like work comp type of issues and things like that. If people are going back to a manual labor job and we talk about rehabbing for 6 to 8 weeks, and they just say that financially, I can't do that. I need you to fix this as soon as we can. And I understand what you're saying about having a little bit of a residual bump, but the sooner you stabilize this, if it'll help me get back sooner, then we go from there. So again, a small minority of my practice, those are the patients that we fix, but we do see. And then I think a little caveat to throw into this as well, that is a similar kind of area, and something that I see maybe just as much, as having people that have like a distal clavicle fracture. It behaves much the same way with when those ligaments are torn, and so those patients I fix right away. So I've had a few of those in recent months that it acts like an AC joint separation, even though it's a fracture through the end of the clavicle. So I don't think those do as well as a pure AC separation. And so those would be a patient, that would be a patient that I'd fix immediately.
Agreed. I think that's right. I think the fractures are a little tougher, and I think the results are a little tougher. So Amanda, Dr. Evans fixes the patient. We talked a little bit about the conservative care. Dr. Evans fixes the patient, sends them over to rehab. When does Dr. Evans send them to rehab after this reconstruction or endobutton repair or whatever he's using? And tell us or walk us through the post-surgical repair rehab protocol.
So certainly we would follow any protocol that Dr. Evans would send over. He was the one in there. He knows what's going on in there. We'll do everything that he says afterwards. I would assume post-op we would be immobilized for a period of time. During that time, we could work other extremity or other joint range of motion. So elbow range of motion, cervical range of motion during that time to maintain range of motion, reduce contracture risk. After that time, we'd start passively. Again, being cautious with overhead movement and adduction movement. From there, we can start active assisted range of motion and then going to active. Slowly but surely after that time, we'll go ahead and add resistance. And same thing, we'll work elbow, wrist, hand to make sure that those joints are all working efficiently and appropriately. Same thing with cervical to make sure that the neck and head are all working adequately so that that upper trap can also give stability to that AC joint.
That's great. So Dr. Evans, post-surgically, you have a go-to time that you send the patients to therapy? Do you immobilize them for a period of time? And what would that period of time be? And then how active do you allow them to be in each, the first 2 weeks, 2 to 4 weeks, et cetera?
Yeah, so if I'm going to reconstruct somebody, I'm pretty slow with letting them move. So the first 6 weeks overall is relatively immobilized. And it kind of depends on the patient. If I feel comfortable with them doing some things on their own at home, like Amanda said, working some of those other joints, making sure their elbow doesn't get stiff and things like that, I'll certainly let them start working on that. I'm okay with them doing some like supine kind of exercises, passive range of motion while they're supine. I think that takes a lot of the stress off the joint. And then by 6 weeks, then exactly what Amanda said about starting passive range of motion, active assist, and then active range of motion, and then going to strengthening kind of stuff from there. And then I would say usually by kind of between 3 and 4 months, patients are doing most of what they were used to in the past. Some nuance in terms of, maybe overhead athletes or things like that. But most laborers and football players, things like that, 3 or 4 months, I'd say, is a pretty good timetable for them.
And when the patient comes in post-op and asks you when they can drive, which is a common theme with upper extremity, what do you tell them? When can that patient drive, and when can that patient go without their sling?
I want them to keep their sling on for up to about 6 weeks or so. And so it really kind of depends on what their situation is. I mean, some people, they might just have to drive a mile down the road to school or something like that. I'm much more comfortable with that than if we lived in a big city somewhere and they're changing 7 lanes of traffic and getting on and off 3 interstates and things like that. So I'm a little bit more liberal with letting patients drive. Most people down here just don't even drive with 2 hands on the wheel anyway, so it doesn't change much for them. So
that was a good answer, actually. So in terms of time frame, we're talking about 4 months back to sports. Is that contact sports as well, or is that golf, or what's the time frame of 4 months, and what's the time frame of going back to contact sports, lacrosse, hockey, etc.?
Yeah, contact sports are tough because I think you worry about whatever you put in, you're adding kind of an increased area of weakness. Like we mentioned, if you're putting some sort of hole through the clavicle or through the coracoid or things like that, and then they get hit, then instead of just having an unstable joint, they might have a fracture on top of that. And then you've got a mess of a situation. And so I'm a lot slower with those. And I think that's part of the pre-op discussion as well, in terms of what are your goals? What do you want to go back to play? If it's a defensive back that is going to be putting his shoulder into everybody that he hits, then I'm really going to advise against having surgery on that if he wants to continue playing, just because I think that puts a huge stress on it. So, but to me, if they've got full range of motion, their strength's the same as the other side, I think that shoulder is as strong as it's going to be. And if that happens at 4 months rather than 6 months, 8 months, or 9 months, I don't have a problem with them getting back to that sport. So, but it has to be, they have to show some functional, I guess, progress. And that's when we kind of rely on the therapist and stuff, and therapists or the athletic trainers at their school and things say, hey, is this shoulder as strong as the other one? Have you truly measured all these things and everything's equal? If that's the case, then I'll let them go back.
I think I also want to see that the patient's comfortable and confident with their shoulder. If they are going to be hesitant in any way, shape, or form, not only are they putting that shoulder at increased risk for injury, but every other body part on them becomes a higher risk for injury, because they're going to be hesitant going into whether it's a move, a catch, a hit. They're just not going to go in with the same confidence, and that can put them at a higher risk for a knee injury, an ankle injury, another fracture, concussion. They just put themselves in bad positions. So I want to make sure that they're 100% confident with that shoulder before going into any type of contact sport.
I think that's a really good point. So let's switch gears for just a second. Patient comes in, they're 55 years old, they're worked construction their whole life, get an x-ray, they have severe AC arthritis, possibly a little impingement. How what are your steps to treat that, Dr. Evans? Is there a place for physical therapy? Is there a place for biologics, for injections? Is there any place for injections at all? How do you treat that chronically arthritic AC joint?
Yeah, I think there is a role for those things. I think most patients with shoulder pathology that I see, whether it's AC joint arthritis, whether it's rotator cuff problems, whether it's biceps tendonitis, they tend to lack a lot of motion and strength no matter what their problem is. So I am very quick to use therapy on those patients. And so if they have pain kind of localized to their AC joint, then I will definitely offer them an injection, a local steroid injection in that area. It's definitely not a radiographic diagnosis. I have a lot of patients that on their x-rays, they look terrible and they have horrible arthritis there, or osteolysis, or a huge osteophyte, and you come in and they have no pain. They have no pain with cross-arm movements. They have no tenderness palpation there. They say, yeah, that bump's been there for years. And those patients, I'm not really going to focus on that as part of their treatment. And then put them through therapy for several weeks, and most of those patients do well. And then if they don't, then there's pretty simple surgical solutions for stuff like that, doing a distal clavicle excision. And whether it's arthroscopic or open, it's one of the few open shoulder procedures I'll do occasionally if somebody has pain localized right there. Almost all of my distal clavicle excisions I do through a scope, because they usually have rotator cuff tears or things like that we're working with as well. But occasionally I have isolated AC joint arthritis that has not responded to conservative treatment, and they might get an open distal clavicle excision.
And I think that's a good point. And I think when you see somebody who's had a failed arthroscopic procedure and you do an open distal clavicle, sometimes you're surprised at how unsuccessful or how not encompassing your arthroscopic procedure really was. So it hasn't happened a whole lot of times. I'll go back, I'll do the clavicle resected open, and I'll be like, you know, I didn't really do a very good job arthroscopically, which leads me sometimes to actually bring in a C-arm and say, do I have an adequate resection? Is there impingement? I want to make sure I haven't created instability, etc. So I think that's exactly right. Is there any reason to do a PRP stem cell in an AC joint treating AC arthritis, or is a typical corticosteroid injection enough?
I'm not aware of any studies showing the efficacy of that in the AC joint specifically. We have some patients that inquire about that specifically. I think a big problem for us in the office a lot of times is they're not covered by any sort of insurance provider. And so that becomes a discussion with the patient about, here's the cost, here's kind of what the studies show. Some people get benefit, some people don't. And I've had some patients do, and whether that's for arthritic problems here, tendonitis in different parts of the body, knee arthritis, it's the same kind of discussion. And it usually comes down to a financial decision for the patients. And some people are okay with spending the money and trying and seeing if it works. There's not a lot of downside to it, I don't think. And other patients just say, well, that's not a financial hit that I can take right now for a maybe it'll work kind of decision.
Excellent. So I think this wraps it up pretty well. One more question, and then I'm going to open the floor a little bit for your final comments. Since golf obviously is a pretty important sport where you guys are, maybe not so much in Missouri, but very important, North and South Carolina, you have your AC joint sprain, somebody falls off a ladder, falls off their bike, they come in, they have a grade 2 sprain. What do you tell that patient when they can go back and play sports like golf, bowling, etc., not non-contact sports?
I actually think golf is great physical therapy, and I kind of stumbled upon that a little bit, I think, based on what you said in terms of like just the patient population we serve. A huge proportion of my retired folks down here, whether it's rotator cuff problems, shoulder replacement, whatever it is, they all love to play golf. And so I think chipping and putting and doing short game stuff, there's not a lot of shoulder range of motion involved in that. There's not a lot of overhead stuff, and it's something that they enjoy. So actually, I use that a lot for patients, telling them, hey, 2 weeks after their shoulder replacement or whatever it is, a rotator cuff repair, just go hit some putts. You're not going to be moving your shoulder that much. And so I get it started as soon as possible. And I also think that patients do a pretty good job in those situations of monitoring how much their arms hurt. And they're not going to, just because I tell them to go putt, all of a sudden take full swings with a driver. Their shoulder is going to hurt too bad for them to do that. So they'll work their way up, and I've yet to have a patient come in that I felt messed something up by going and practicing on the putting green.
I think that's excellent. And I do that as well. Say, go ahead. I had a guy today, did his rotator cuff. He said, when can I play golf? I said, look, go in your backyard, take the club head back, see how it feels, and progress as it feels. And I agree with you. I think there's very little stress on, and I think that's important for therapists as well, to say, hey, there's very little stress on the rotator cuff. There's very little stress if you've done a arthroplasty. So give it a go and let them self-limit. So I think that's very, very good advice. So Amanda, closing thoughts, anything we didn't talk about, we should talk about, anything therapy-wise we forgot?
I will second the love of the golf swing, as it's an active assisted movement, and a lot of us don't have a Dustin Johnson type swing where we're really getting the club all the way behind our head. So those patients with these shoulder injuries, golf is a great therapy for them. Not only does it keep their range of motion going, but it does help to promote strength. So I'm all for golf, putting, chipping, and as they get back to their game, we just slowly work up to their normal swing. But now AC joints, they do great. And like Dr. Evans said, conservative care is pretty much the better way to go, as opposed to operative care if we can stay out of it, especially for those shoulders that aren't overly unstable.
Excellent. And thank you very much. Dr. Evans, closing thoughts.
And I agree with what she said right there. I think this is one of those injuries when somebody comes in with this problem, my first thought is, how do I avoid operating on this patient? How can we keep them out of the operating room? Because exactly what Amanda just said, most of these patients are going to do really, really well. And I think the biggest thing is helping them get over the cosmetic part of having a bump and reassuring them that it's not going to cause any function. And some people just, they don't believe that until they start going through the therapy, and then they come back and they realize that, yeah, my shoulder does move pretty well. It doesn't hurt. I can do everything that I wanted to. But I think that's the mainstay of treatment for these.
I think that's right. And I think a lot of this is hand-holding, because AC joint injuries are so painful in the beginning. They just can't imagine that they're going to get by without surgery. And again, I think there's very little indications, or very few indications, for surgical resolution of an AC joint injury, and that would be a failed conservative care where they had chronic pain. But I think once they get 2-3 weeks into therapy, they realize they got the range of motion back, they're really not having any soreness, you tell them that they're clicking and their grinding is going to go away, I think they start to believe you. And I also tell them, which I think helps them, that the only person that's looking at that bump is them. No one's looking at you at the mall saying, oh my gosh, look at Dr. Evans with that big bump on his shoulder. So based on that, I think it's not as cosmetic unless you have a grade 5 or a 4 and it just is disfiguring. And then again, as you said before, that might be an indication for a clinical reconstruction. Everybody, you guys were awesome. I want to thank you very much, and we'll do this again soon sometime.